Imagine getting like all the muscle building benefits of loading up a massive barbell for heavy squats. The sheer strength, the joint stability, the muscle size.
Right.
But you are only lifting a fraction of the weight, and all it takes is tricking your muscles with a high-tech tourniquet.
It sounds like science fiction, honestly.
It really does. Okay, let's unpack this. Today, we're taking a deep dive into a fascinating 2026 clinical trial from the JOSPT Open journal.
Yeah, it's all about rebuilding the knee after a major anterior cruciate ligament or, an ACL reconstruction.
Right, and our mission here for you listening is to extract the most critical insights from this research. We want to figure out if cutting off blood flow to a healing leg can actually replace traditional heavyweight lifting in early surgery recovery.
And to really grasp why researchers are even attempting this kind of physiological trickery, we need to look closely at the inherent dilemma of ACL rehabilitation.
Which is a huge hurdle.
Exactly.
Yeah.
I mean, if you're listening to this and you've ever had a severe joint injury, you know the immediate aftermath. The muscle simply disappears.
Just vanishes, yeah.
Right. So we have to understand the specific surgical procedure the patients in this study went through to see why preserving that muscle is such a monumental challenge.
Right, because there isn't just one way to fix an ACL.
No, there are several.
But the patients in this specific trial underwent what's called a bone patellar tendon bone reconstruction, or a BPTB graft. Walk us through what that actually means for the patient lying on the operating table.
Well, when a surgeon repairs a torn ACL, they can't just stitch the two ends of the ligament back together.
Oh, really?
Yeah, it doesn't work that way. They need a completely new piece of tissue, a graft, to serve as the replacement.
Okay, so where does that come from?
With the BPTB method, the surgeon goes right to the front of the patient's knee, they take a strip of their own patellar tendon, and they actually cut out tiny bone blocks from the kneecap at one end and the shin bone at the other.
That sounds incredibly invasive. Why take the bone blocks?
I know, it sounds brutal, but it creates an incredibly stable, robust new knee. Bone heals to bone much faster and stronger than soft tissue heals to bone.
That makes sense.
Yeah, so mechanically, it's a fantastic repair. The massive downside, however, is the collateral damage to the front of the knee.
Because you just harvested part of the kneecap.
Exactly. Because you've harvested tissue right from the patellar tendon, this specific graft procedure results in significantly higher rates of severe quadriceps weakness and anterior knee pain compared to, say, using a piece of the hamstring from the back of the leg.
It simply hurts to fire the thigh muscle.
It really does.
Which sets up the physical therapy problem. Because the gold standard to get that muscle back and prevent the leg from withering away is heavy load resistance training.
Right, the HLRT.
Yeah. So if I'm a patient trying to rebuild my quad, I'm supposed to be lifting more than 60% of my 1 repetition maximum. But if my knee is screaming just from the harvest site, how am I supposed to load up a heavy leg press?
You really can't. That 60% threshold is widely considered the minimum mechanical tension required to signal your body to build meaningful muscle.
Right.
But as you pointed out, we have a brutal catch-22 here. Lifting heavy external weights creates excellent tension for the muscle fibers. But it places immense mechanical stress on a freshly healing joint and that newly implanted vulnerable ACL graft.
It basically sounds like putting the full weight of a 2-story house onto a foundation where the cement was poured, like yesterday.
That is a perfect way to look at it.
I mean, you need the house to be built, but the sheer weight of the materials threatens to collapse the entire structure before the concrete has even had a chance to cure.
That perfectly illustrates the risk. The knee joint desperately needs a strong quadriceps muscle to act as a shock absorber and stabilize it.
Right?
But the very act of building that muscle with heavy weights jeopardizes the integrity of the joint.
So if driving those heavy trucks over a wet cement foundation is a terrible idea, there has to be another way.
Which brings us to the core of this 2026 study.
Exactly. Low-load blood flow restriction training, or LL-BFRT. How does this solve the wet cement problem?
Well, the foundational concept of BFRT is to lower the physical weight entirely. Instead of hoisting 60 or 70% of their maximum capacity, the patients in the BFRT group of this study were only lifting 20 to 40%.
Wow, that is a huge drop.
It is. Specifically, the researchers standardized it So every patient in that group was working with exactly 30% of their one repetition maximum.
Okay, here's where my brain hits a wall.
Yeah.
You can't just lift light, feathery weights and expect to get massive, strong legs. That violates everything we understand about progressive overload and resistance training.
It does sound counterintuitive.
All right, like if I just lift a soup can 100 times, I'm not going to get strong.
Under normal circumstances, you are entirely correct. But this is where the restriction aspect completely changes the physiological environment.
Okay, how?
To make those incredibly light weights effective, the researchers applied a specialized pressurized cuff to the very top of the patient's upper thigh.
A cuff, like a blood pressure cuff.
Very similar. The cuff is inflated to a precise pressure designed to do one very specific thing: occlude or block the venous outflow of blood from the leg back to the heart.
Okay.
But, and this is key, while still allowing the arterial inflow of fresh blood from the heart down into the leg.
Wait, I have to push back here.
Sure.
So we are intentionally wrapping a tourniquet around a patient's leg, trapping all their blood and the burning lactic acid and forcing them to exercise.
Yes, essentially.
That sounds like a medieval torture device, not a modern physical therapy clinic. I mean, how on earth is it safe to cut off circulation to a patient recovering from major orthopedic surgery?
I get that reaction a lot, but what's fascinating here is the sheer sophistication of the technology.
Okay, so it's not just a tight band.
No, we are absolutely not talking about tying a rubber resistance band tightly around a leg.
Right.
The study utilized an automated personalized tourniquet system, or PTS.
Oh, so it's essentially a smart cuff.
Exactly that. The machine constantly calculates a metric called the limb occlusion pressure, or the LOP.
LOP, got it.
It uses sensors to find the exact minimum amount of pressure required to squeeze the veins shut without completely crushing the deeper arteries.
So the blood can get in, but it can't get out.
Precisely. Fresh, oxygenated blood continuously pumps into the working muscle. But because the veins near the surface are pinched off, the oxygen-depleted blood, the lactic acid, and all the metabolic byproducts of the exercise cannot escape. They just pool in the leg.
What does that pooling actually do to the muscle, though? Why does trapping the waste products make a lightweight feel heavy?
It creates a state of severe metabolic stress. As the lactic acid builds up and oxygen levels locally drop, the environment inside the muscle becomes incredibly acidic and fatigued.
Oh, so the body panics.
Exactly. The brain senses this extreme distress. It genuinely thinks the muscle is failing against a massive heavy load.
Even though it's just 30%.
Right. So in response, the nervous system bypasses the slow-twitch endurance muscle fibers and starts aggressively recruiting the fast-twitch, powerful muscle fibers.
The same ones you'd use for heavy lifting.
Yes, the exact same fibers you would normally only recruit if you were squatting a heavy barbell.
That is wild. You are quite literally tricking the nervous system.
It's a complete physiological hack.
And because of that trick, the exercise regimens between the two groups in the study looked completely different, right?
Very different, yeah.
Like the heavy lifting group did a standard routine, 3 sets of 10 reps at 70% of their max, a normal gym day.
Yep.
But the BFRT group, they had to do 4 sets with a huge number of reps. It was like 30 reps out of the gate, followed by 3 sets of 15 reps, all at that light 30% weight.
Right, because the high repetitions are necessary to generate that metabolic accumulation. You have to keep pumping the muscle to trap the blood and force the brain into that panic state of fiber recruitment.
Okay, so to see if this metabolic trick actually works as well as traditional heavy lifting without destroying the knee, researchers in the Netherlands and Belgium set up a randomized controlled trial.
I did.
They took 28 patients, and 23 of them made it through the entire protocol and ran them through a gauntlet from week 2 post-surgery all the way to week 14.
It was a very rigorous timeline.
But I am still hung up on the exercises they chose. They had them doing unilateral leg presses, seated leg extensions, deadlifts, and squats.
Those are demanding multi-joint movements, even at light weights.
Demanding is an understatement. I mean, if someone drilled into my shin bone 14 days ago, the idea of doing a leg extension sounds like a recipe for snapping the new graft in half.
It sounds scary for here.
Like making a newborn baby run a marathon. Even with light weights, how did the physical therapists ensure these patients didn't just ruin their knees?
Well, the key to the study's safety profile wasn't just the tourniquet. It was the strict entry criteria.
Okay, so they didn't just let anyone start.
No, they didn't simply look at a calendar, see that 14 days had passed, and force everyone onto a leg press machine. Every single patient had to pass a physical checklist before they were allowed to touch a single weight.
What were the milestones?
First, they needed a pain-free knee range of motion from perfectly straight, so 0 degrees, to at least a 90-degree bend.
Okay, that makes sense.
Second, they had to present with minimal to no joint swelling, clinically referred to as effusion. If the knee was still an inflamed, swollen balloon, they were disqualified for that week.
Gotcha. What was the last one?
Finally, they had to demonstrate complete motor control of the quadriceps by performing a straight leg raise without any muscle lag.
Meaning their brain could fully connect to the muscle without the leg buckling or drooping?
Exactly.
So if they failed any of those, they simply waited and focused on basic mobility until they passed.
Yes, safety first. Once they hit those milestones, then the 12-week clock started.
But even passing those criteria, putting a newly operated knee on a standard gym leg extension machine feels risky. You mentioned the study specifically used Kaiser pneumatic machines and a Kineo system.
They did.
What makes those different from what I'd find at my local gym?
The equipment selection was highly deliberate to protect the graft. A standard leg extension machine uses stacks of iron plates.
Right. Clanking up and down?
Exactly.
Yeah.
When you kick up, you create momentum. If you stop suddenly, gravity pulls that iron down, creating a jerking force that can place massive shear stress on an ACL graft.
Oh, yikes.
The Kaiser machines, however, use air pressure instead of iron. There's no momentum. The resistance curve is perfectly smooth.
And the Kineo system?
The Kineo system provides what's known as no inertia training. It uses a motorized system to provide constant uniform resistance.
Okay, so no sudden jerks.
Right. Whether you're pushing fast or slow, the machine matches your exact force output at every single millimeter of the movement. If the patient feels pain and suddenly stops pushing, the weight simply vanishes.
Oh, wow.
It doesn't crash back down on them. Plus, they mechanically lock these machines to prevent the knee from bending past 90 degrees, ensuring the graft was never placed in a vulnerable, stretched position under load.
So we have a highly controlled environment, strict entry criteria to make sure the foundation is somewhat dry, smart tourniquets tricking the brain, and air pressure machines eliminating dangerous momentum.
Exactly. They controlled every variable possible.
So when they pitted the heavy lifters against the blood flow restricted light lifters at the end of the 14 weeks, what did the data actually show?
Well, to measure the true outcome, they didn't just ask the patients how strong they felt. They used a specialized leg pro machine to measure isokinetic strength at 3 distinct speeds, or angular velocities.
Okay, what were the speeds?
60 degrees per second, 180 degrees per second, and a rapid 300 degrees per second.
Wait, why test at different speeds? Isn't strength just strength?
Not functionally. A muscle behaves very differently depending on the demand.
Oh, I see.
Testing at 60 degrees per second measures brute force, like the slow, grinding effort of walking up a steep flight of stairs. Testing at 300 degrees per second measures explosive power.
Like catching yourself if you trip.
Yes, the kind of rapid muscle firing you need to catch yourself if you trip over a curb or land from a jump. They needed to know if the muscle was functional in the real world.
And across all those speeds, what happened?
The outcome was a statistical tie. There were no significant differences in quadriceps strength, hamstring strength, recovery of range of motion, or joint effusion between the heavy lifting group and the BFRT group. Both groups effectively rebuilt their legs.
Okay, here's where it gets really interesting, though.
Oh.
I was looking at the pain statistics reported by the patients, and I want to challenge this idea of a tie.
Let's hear it.
The researchers noted that 14.3% of the BFRT group reported increased knee pain over the course of the study. Meanwhile, 35.7% of the heavy lifting group reported increased pain. Wait a minute. 14% versus 36%. That means the heavy lifters were in pain more than twice as often. Why on earth are the researchers calling this a statistical tie? Practically speaking, that sounds like a massive victory for the tourniquet group.
It is a totally valid reaction, and it highlights a crucial gap between raw clinical observation and formal statistical proof.
Because mathematically, those numbers look way different.
When we read clinical trials, we have to understand how mathematical power dictates the narrative. If you just glance at the percentages, BFRT looks clearly superior for pain management. But the researchers are bound by the math.
Okay, walk me through the math. Why doesn't double the pain equal a loss for the heavy lifters?
It comes down to how the question was asked and how many people answered it. The study didn't give patients a sliding scale from 1 to 10 to track the nuance of their discomfort.
What'd they use?
They used a simple dichotomous survey question. Did you experience increased knee pain during the past 24 hours? Yes or no?
Oh, so it's completely binary. Black and white.
Precisely. When you take a binary yes or no question, and apply it to a relatively small group of people. And remember, only 23 patients actually finished this study. The mathematical margin of error is enormous.
I see.
Think of it like flipping a coin. If you flip a coin 10 times, getting 7 heads and 3 tails doesn't prove the coin is rigged. The sample size is too small to rule out random chance.
Right.
But if you flip it 10,000 times and get 7,000 heads, then you have statistical proof.
Got it. So because the sample size was so small, the statistical formulas, I think they mentioned the Benjamini-Hochberg procedure, couldn't definitively say that the 14 versus 36% difference wasn't just a random fluke of the specific 23 people in the room.
Exactly. The math says the gap is not statistically significant. However, as clinicians, we can look at that data and recognize a strong trend.
Knowledge is most valuable when understood and applied, right?
Exactly. The math can't declare a formal victory, but the trend strongly points toward the lightweight BFRT protocol being far less irritating to the joint than hoisting heavy iron.
That actually sets up a fascinating conflict with past research.
How so?
Well, if this robust 2026 study found a mathematical tie in muscle strength, why did previous older studies, the paper specifically points out, trials by researchers named Hughes and Vieira, conclude that BFRT was actually superior to heavy lifting for gaining strength? Did human physiology change in 8 years?
Physiology remains constant, but methodology evolves. If we zoom out and look at how those older studies were designed, we find a glaring flaw in how they treated the heavy lifting control groups.
What was the flaw?
In the Vieira study, for example, they started patients on heavy load resistance training in the very first week following their ACL reconstruction.
Week 1. The cement on the foundation is still pouring and they are driving the trucks over it.
Yes. They initiated heavy loading without implementing the strict, criteria-based milestones the 2026 study used. They weren't checking if the swelling was under control or if the patient could perform a lag-free straight leg race.
So it's not that blood flow restriction is some magical superior muscle builder that naturally beats heavy lifting.
Right.
It's that in the older studies, the heavy lifting group was essentially hobbled right at the starting line. They weren't physically ready to run the race, so of course they lost to the lightweight group.
That is the most accurate synthesis of the data. Because those early heavy lifting patients weren't ready, their knees simply couldn't tolerate the 70% maximum loads.
They probably missed workouts.
Exactly. They missed sets, they skipped sessions due to pain, and they had a significantly lower total exercise volume over the duration of the study. And if you do less physical work, you build less muscle.
Whereas in this new 2026 trial, because the physical therapists forced everyone to pass those strict swelling and mobility milestones before touching a weight, the compliance rates were phenomenal.
Well, they were fantastic.
The data shows 92% of the prescribed sessions were fully completed by the BFRT group, and an astonishing 95% by the heavy lifting group.
Right. When you create a scenario where both groups are actually capable of completing their respective protocols, the physical outcomes equalize. Which is wonderful news because it proves that low-load BFRT is a fully viable, reliable alternative. It's not necessarily a magic bullet that invalidates heavy lifting.
Okay, but if it's a perfectly viable alternative that seems to cause less joint irritation, why wouldn't every physical therapist in the world just throw away the heavy weights and use smart tourniquets tomorrow? There has to be a catch.
Well, you're right. Altering human cardiovascular dynamics is never without risk.
Let's talk about the fine print and the safety caveats.
Trapping blood in an extremity forces the heart to adapt. During this trial, one patient in the blood flow restriction group actually fainted during their very first session.
Wait, really? They passed out just from exercising with a cuff on their leg?
Yes. While fainting, clinically known as syncope, is historically rare in BFRT, occurring in less than 4% of recorded cases, the physiological mechanism behind it is important to understand.
What happens in the body?
Your heart is working hard, pumping a high volume of blood down into the legs, but the tourniquet traps it there. This causes massive local pooling.
Okay.
When you suddenly release that cuff, or if the patient's nervous system simply gets overwhelmed by the localized pressure, the body's control over its blood vessels can momentarily glitch. Blood pressure drops rapidly, blood flow to the brain momentarily dips, and the patient faints.
Wow, that sounds terrifying for a patient already nervous about their knee.
It is unsettling. And what triggers that nervous system glitch in patients with healthy hearts is often just the sheer stress, anxiety, or acute pain caused by the tourniquet itself.
And to be clear, the cuffs in this study were brutally tight.
Very tight.
They calibrated the machines to 80% limb occlusion pressure. meaning they squeeze the leg with 80% of the force required to completely sever all blood flow. Having a machine crush your thigh while you try to do 30 reps of a leg press has to be agonizing.
It is highly uncomfortable, and many patients outright struggle to tolerate an 80% occlusion pressure. But here is the good news, hidden in the discussion section of this paper.
Oh, there's good news.
The authors highlight a very recent systematic review of BFRT literature that shows you don't actually need to squeeze the leg that hard.
Really?
The data now suggests that using only 40% occlusion pressure is just as effective for producing the metabolic stress needed for strength gains.
Wait, you can get the exact same brain-tricking muscle growth with half the crushing force.
Yes. The evolving clinical recommendation is to stop defaulting to 80%. Physical therapists should start patients closer to 40% occlusion. This allows them to build familiarity and tolerance to the strange sensation of blood pooling.
Which would drastically reduce the anxiety and pain that leads to fainting.
Exactly.
Now, it's also worth noting a couple of limitations the researchers themselves pointed out. This wasn't a blinded study because, while you can't really hide a giant inflating blood pressure cuff from a patient, they know which group they are in, which can influence how they report pain. And they didn't meticulously track the total exercise volume in pure kilograms, which leaves a slight gap in the data.
Both true.
So what does this all mean? If there is a risk of fainting, and it's uncomfortable, should the average listener who just tore their ACL playing weekend soccer actually ask their doctor for this? Or is this reserved for elite athletes?
The clinical application here is profound for the average person. The ultimate takeaway is this: if you, or a loved one, undergoes an ACL reconstruction, particularly the BPTB graft that harvests from the front of the knee, and the early joint pain makes lifting heavy weights impossible, you do not have to surrender to muscle atrophy.
You have another path forward.
A scientifically validated path. When utilized by a trained physical therapist, starting with criteria-based milestones to ensure the knee is ready, low-load blood flow restriction training is a safe, highly effective tool.
That's great to hear.
It allows you to keep your rehabilitation perfectly on schedule, yielding the exact same muscle strength and functional range of motion as if you were grinding through heavy iron, but at a fraction of the mechanical weight.
It is a massive breakthrough for physical therapists who hit a roadblock with a patient in pain. You don't have to push through dangerous levels of load. You can simply work smarter.
Exactly.
Thank you for joining us on this journey of discovery today. We've taken a dense, complex clinical trial and bypassed the academic noise to get you straight to the physiological mechanics that matter.
The adaptability of the human body never ceases to be fascinating.
And I want to leave you with one final mind-expanding thought. We've spent the last several minutes hyper-focused on knee surgery and ACL recovery, but if restricting blood flow can effectively trick a post-op patient's leg into thinking it's lifting heavy weights while they are barely lifting anything, imagine what this technology could do in extreme environments. Think about astronauts experiencing rapid, devastating muscle atrophy in the zero-gravity environment of space where heavy weights literally don't exist.
Oh, wow.
Or think about the elderly in our own communities who simply no longer have the joint cartilage or the skeletal strength to lift a barbell, but desperately need to maintain their leg muscle to prevent fatal falls.
That is a huge application.
The implications of this muscle-tricking tourniquet go way, way beyond a torn ACL. Keep exploring, keep questioning how your body works, and we'll catch you on the next deep dive.